You recall, again, those 5 regions, northern to southern California, San Joaquin Valley, the Bay Area, and the greater Sacramento regions. The regional stay-at-home order went into effect after a region fell below 15% ICU capacity. In order to come out of the stay-at-home order, as Greater Sacramento region did just recently, we project forward over a 4-week period, and we determine ICU capacity either meets or exceeds 15%. And I want to talk more, and Dr. Galley's here as well, to talk more about our projections and our confidence level as it relates to the decision that we are announcing here today. Here is the projection of capacity on February 21st. This is 4 weeks from today. We look again at capacity, looking through the lens of a number of variables. Clearly, estimated ICU capacity, that's foundational, 15% being that baseline. But we also look at community transmission rates. Remember, ICU is a lagging indicator. What's happening with positivity rates, case rates, community spread, really is the forecast that gives us confidence on where we will land in a number of weeks. We look at case rates, more broadly defined, on a regional basis, and clearly we look at the proportion, that percentage. Dr. Galley's talked a lot about this percentage of cases, individuals that are hospitalized that end up in the ICU. So you can take a look here at the regions, these being the 5 regions in the state. Our projection statewide is in the aggregate being at 30.3%. on the 21st of February. There are, again, variables that are constantly changing, but these are the projections. You can see in Southern California, it would exceed even that state rate. San Joaquin Valley, a little bit below, Bay Area, tiny bit below, Greater Sacramento, Northern California. So the goal of this announcement is to socialize our projections, as well as illuminate and further advance an understanding, a deeper understanding of what today means and what it doesn't mean. And it's in that respect that I want to remind folks we're not out of the woods. We're seeing a flattening of the curve. Everything that should be up is up. Everything that should be down is down. Case rates, positivity rates, hospitalizations, ICUs, testing starting to go back up, as well as vaccination rates in this state, but we are not out of the woods. I'll remind people that blueprint was established with purple, red, orange, and yellow tiers. We simplified that blueprint a number of months ago. Many of you, again, recall that blueprint on the basis of the most restrictive tier being the purple tier and the least restrictive tier being the yellow tier. Here's our current tier status. And by the way, tomorrow, this status will be updated when Dr. Galley gives his Tuesday presentation. But you can see the current status and all the commensurate requirements, modifications, and restrictions that are part of each tier. And I'll remind everybody, if they want to learn more about the tiering and remind themselves or just dust off a little bit of understanding of what red means versus orange, go to the covid19.ca.gov website, covid19.ca.gov website. Purple tier, just as an example, and now that we are in purple tier for those vast majority of counties, means restaurants can open for outdoor dining with modifications. Nail hair salons can open with modifications. Certain youth sports can resume for competition in particular with, again, modifications and considerations. I noted that tomorrow the update in those tiers, on those tiers, will be provided by Dr. Galley, and will consistently update in hope and expectation if these trend lines continue, that we'll be moving, we hope, quickly through tiers, again, based upon our behavior, individually, collectively, based upon our success at continuing to mitigate the growth and spread of this virus. Today, we can lay claim to starting to see some real light at the end of the tunnel as it relates to case numbers. You can see the 27,000 number. That's reflected on over 400,000 tests that came in on that reporting period, 403,000 tests On January 24th, 27,000 cases. The 7-day average now below that 27,000 based upon the 400+ thousand total tests, not surprisingly. But the encouraging sign is that 7-day average down to 23,283. Take a look at the positivity rate. Now, this is the 14-day positivity rate now is down to single digits to 9.4%. It was substantially higher just a few weeks ago. You could take a look here at 13.6%. 2 weeks ago, 9.4% today. The 7-day rate, even more favorable. Again, 14-day rate at 9.4%, but the 7-day positivity rate's down to 8% in the state. And I want to put this in perspective. People often ask or often overlook how we're doing vis-a-vis other states in this respect on positivity rates. We're faring better than more than half the states in the nation. Florida, and I compare some larger states here, Florida, Texas being notable large states, Pennsylvania from a population perspective certainly, and Arizona just in terms of its regional proximity. And so you can see those positivity rates just as a proxy example of where we are. And this, again, data from Johns Hopkins based upon data was collected on the 25th. Hospitalizations are down just shy of 20% now in the state over a 2-week period, down. Not a rate of increase declining as we've seen in the past. Now we're seeing a decrease, consistent decrease, all part of our projections, all part of our understanding in terms of the impact that positivity rates have on case rates, percentage of people that end up in the hospitals, and then a percentage still that end up in ICUs. And you see a 9.5%, close to 10% decrease over a 2-week period, 14-day period in ICU admissions, again, statewide. I'll remind everybody, this is statewide data. Each region's a little bit different, but we are in a position projecting 4 weeks forward with a significant decline in the case rates, positivity rates. We are anticipating decline, still more decline in hospitalizations and more declines in ICUs, and that's why we're lifting that stay-at-home order effective immediately today. Here's a reminder of some of the things we've done and some new information. We have substantially increased the number of staff, federal and state staff, that we've deployed in the last few weeks. We had some stretch goals of getting 1,000 over the last week. We're actually able to exceed that. Over 5,175 clinical staff now have been deployed. And remember, staff often means ICU capacity, which means we're expanding that capacity. It's not static ICU capacity. We could expand that ICU capacity. We've got these alternative care sites that we have opened up, 15 across the state, more resources, more equipment, oxygen supply issue. We've talked about that in the last few weeks in our oxygen task force and some of the interventions and efforts that were advanced there. We have made progress. We also have been able to transfer critical patients to the hospital, again, part of the regional understanding, the mutual aid system that exists within the regions that has also helped advance our efforts to address and respond to the surge. Over 1 billion now pieces of PPE have been delivered, and we have, as you know well, prioritized vaccinating the vaccinators, vaccinating our healthcare workers as a top priority. Deaths continue to be significant, and this is a sober reminder of how deadly this pandemic remains, more so now than ever. As we have battled our way through the most challenging surge and now are seeing truly light at the end of that surge, at the end of the proverbial tunnel. You could see here just the 7-day average of deaths, 504. It's just a reminder of how important it is until we get vaccinated, of maintaining our vigilance, avoiding mixing, and continuing to do what we must to protect ourselves and our loved ones, and more broadly, the community that we share. Here's good news as it relates to vaccines, which are the ultimate advancement to addressing substantively those mortality, morbidity rates, and more broadly, this pandemic. We have tripled our rate of administration of the vaccine, and I'll show you a chart that marks the period of time, and we're just getting going. I've made this point over and over and over again. It's a flywheel, not dissimilar to what happened in the beginning here in California with the testing, but you can see with over 400,000 tests just yesterday in California. By the way, over 40 million tests this state has conducted, close to 41 million total. It gives you a sense, California, size of 21 states in America combined. This is more like a large ship. It takes a little bit of time to shift course, but when it shifts course, builds tremendous momentum. That's exactly what we have done, and you'll continue to hear more about as it relates to our vaccine administration in the state, tripling, and we are on a good pace. Here is an example. Just on the 4th, just a few weeks ago, we were doing daily vaccines of around 43,000. On the 15th, just as an example, just a 2-week period, you get a sense, or 10-day period, 131,000 vaccines. We want to see that substantially increase. We have some medium-term goals, long-term goals. We have some short-term goals. We'll be talking more about those, but certainly we want to see those numbers continue to increase significantly, and that will be a combination of many, many factors, a number of which we will discuss here in a moment. You may recall a few weeks back, we talked about this 10-day challenge. The 10-day challenge was really an opportunity to set a goal that at the time didn't appear achievable, but in the process of pursuing it, we would develop a greater understanding of what the challenges were, what the issues were as it relates to accelerating that last mile, that last inch, perhaps, but that last mile in particular as it relates to the administration of vaccines. Over the course of that period of time, we recognized the opportunity to simplify our eligibility framework. You've heard a little bit about that with the 65-plus cohort that we have advanced. We'll talk a little bit more about that in a second. We're also looking to standardize our information and data. Data has become a big issue. That has become a big challenge for us. The data lag that's led to some data that's provided nationally that did not represent the data that we have internally, meaning we're a number of days behind what the national numbers reflect in terms of the actual number of vaccines administered. And we could talk about why that's the case, and we are certainly happy to do that, but more importantly, what we're going to do about it is really our focus here today and moving forward, and frankly has been our focus for now a number of weeks. Supply being a big part of also getting to goal, and that is getting to herd immunity, getting to vaccines to everybody that wants them administered, and getting to a point where we can go back to some semblance of the new normal with all the resiliency that now resides within each and every one of us, and ultimately will reside in the state and the nation and more broadly the world post-pandemic. So we have specifically addressed the issues around simplification by, as I noted a moment ago, clarifying that we believe that the cohort 65 and over needs to be prioritized alongside healthcare workers, first responders, food and agriculture workers, and school staff and teachers. So I want to make this clear. We want to continue to provide a framework of prioritization in that cohort. 65 and over, remember, 75% of the deaths are reflected in people 65 and over. We want healthcare workers to continue, want to work through that cohort, our original tiered strategy consistent with the CDC, and continue to do what we can to vaccinate the vaccinators, our first responders, our farm workers, our critical workers on the front lines in our food delivery system, and our teachers in order to get our schools reopened, as well as our support staff that's so foundational and critical not to ever be forgotten as it relates to making schools work. This, by the way, is analogous. It's not more complicated than whenever you've been to an airport and you're about to board on an airline. They say, well, ladies and gentlemen, all first-class passengers. Well, they don't wait for every first-class passenger to be boarded before they announce all business class passengers. Accordingly, they don't wait for all business class passengers before they announce premium class and then ultimately the economy class. The point is to try to move folks to board as quickly as possible, but with prioritization. That's reflected here, 65 and over, and those cohorts that are represented. We want to, though, more importantly, as we work through this cohort, begin to transition. And you'll hear a lot more about this tomorrow in Dr. Galley's update. And so we'll happily take some questions today, but tomorrow you'll hear a lot more about the details of a strategy to transition, once we work through those cohorts represented here clearly, to an age-based eligibility, which will allow us to scale up much more quickly and get vaccines to impacted communities much more expeditiously. With the framework always on equity, we're not losing sight of any of those fundamentals, any of our values, but we realize we have got to increase throughput here. And while we are proud of the framework we put out, CDC put out, and others, we recognize it has advantages and it has disadvantages as it relates speed and efficiency. Look, I get this. This slide represents what you individually and what's represented, I assure you, in my inbox are most concerned about. When is it my turn? When is my number up? And I've got a sister, I've got a brother, I've got a pre-existing condition, I'm not 65, I'm 64, all of these questions, appropriate questions, everybody getting them here in the nation's largest state. So when is your turn? Where can I get vaccinated when it is my turn? So what we are announcing here is a standardization information database. We announced it a few weeks ago that we were going to get it done by the end of January. We have gotten this pilot up, as we noted a few weeks back, and we'll talk about that in a moment, what the new platform is. But we have now developed, we believe it's the most comprehensive end-to-end system of its type in the United States. But again, we acknowledge it's in its pilot phase. Again, we'll talk more about that in a second. But it's a centralized system to enter vaccines, received and administered, and it's a mechanism to fundamentally address the supporting lag, which again is very stubborn but very real. Those national numbers you see do not reflect the numbers of vaccines that have been administered. That said, we have a solution to that, and that is leveraging the innovation, the technology, leveraging some of California's finest companies. We have a new scheduling system and a new data system. Again, it's end-to-end. It's not just a notification system, as some other states have, or a system for reservations just with state clinics. This is an end-to-end system across the spectrum, bottom-up, top-down, providers, whole spectrum of the delivery system, and a database that allows more immediate data to be transferred to the CDC, and that index that is so often referred to and reflected in our nightly news. That said, the idea is not very complicated. We want to provide you the opportunity to sign up on this app, the MyTurn platform. You sign up, you get notified via text or email when it's your turn. You could schedule an appointment when it's your turn. As I said, it provides for providers the ability to have all that data automatically shared, not only with the state, but ultimately allow us to quickly share that data with the federal government. So back end, front end, what you care about, when's my time, when do I get a schedule, when do I get a vaccine, when am I scheduled, and how close is it? And then, of course, for providers, all of that, well, difficulty with paperwork and the prompted questions and the old systems that many states, not just the state of California, is struggling with. We partnered with Salesforce. We partnered with Scheduler, which is a great company, and Accenture. We've got a pilot up and running. We started this last week in LA and San Diego. They started allowing individuals 65 and over, again, with the prioritization of the cohorts we just mentioned a moment ago, to make appointments for those clinics that have signed up and come in to the pilot. And so the most important point I want to make about the MyTurn pilot, it's only as good as the clinics and provider network is good. It gets more robust as more people come online. And so in the pilot phase, we're moving judiciously, but we're moving relatively efficiently. But as more and more clinics sign up, more and more opportunities avail themselves, more and more capacity is made available, at least on this platform, versus other mechanisms and platforms in terms of finding out when it's your turn to get vaccinated and how and where you can get vaccinated. So we're aiming for a statewide launch. We picked LA, not a small county, and San Diego, two of the biggest. So we went big and bold on the pilot, but we want to bring it to the rest of the state, and we hope to do so in the next few weeks. We'll be talking more about that. We just want to make sure we get this up. As I said, it's the most robust end-to-end system of its type that any state's put up, so it's got a lot more components, and we just want to make sure that we don't run this thing into the ground and have a system that shuts down. And by the way, there's been some other states, not an indictment, quite the contrary. We all should be humbled by the magnitude of this moment. We saw it on the unemployment side. Everything is at scale now in terms of need. We've had other systems that have actually crashed within a few hours because so many people went on or overwhelmed. That's why we're limiting this, focusing it on this pilot in these two parts of the state. And so we continue to work with providers, and we continue to advance the cause of getting more and more people to participate. And we look forward to, again, getting this out statewide in just a number of weeks.